Everybody ready for the second day of the World Convention 2018 here in Kansas City? Awesome. So family, my name is Jason Brand. I'm a person in long-term recovery. What that means for me is I've not found it necessary to use a mind or mood-altering substance since November 3rd of 2015. Couple quick reminders. If you've got a cell phone, please make sure to turn that off or to vibrate to not disrupt the panelists. Another reminder, if you smoke or vape, make sure you're doing that in the two covered areas in the front of the building, not to block the doors to enter the hotel. If you ask a question later to one of the panelists, please speak directly into the microphone and wait till the microphone is in front of you. So this session is being recorded so we can hear and get your question on tape. If you have the Oxford House Convention app, please remember to rate the session as well. This morning, you're at the Medication in Oxford Houses panel. We're going to hear from Dr. Ken Hoffman. He's a retired colonel from the United States Army and been a supporter of Oxford House for a number of years. Everybody wants to give a round of applause for Dr. Hoffman. Then we also have Paul Stevens, who is an Oxford House alumnus and regional outreach manager for Virginia, D.C., and Maryland. If you want to give him a round. We have Daryl Joyner, who is Oxford House alumnus and central office staff and the voice of Oxford House. Give him a round of applause. And then we also have Kimberly Nelson, who is the SAMHSA regional administrator here in the Kansas City, Missouri area. All right, so about half of the residents of Oxford House have a physical or mental health disorder that requires medication to control. This panel will sort through the medicines that fit within an Oxford House environment and those that undermine the alcohol and drug-free foundation of Oxford House living. The panelists will discuss the use and misuse of medicine within an Oxford House. Some medicines are not permitted because they may be illicit or cause mood-changing behavior and be addictive. On the other hand, some medicines are correctly prescribed and may be necessary for controlling serious mental illness or making a transition from addictive use to comfortable sobriety. The panel will consider how such situations are handled and steps are taken by Oxford Houses to assure that the person with the prescription or others in the house do not misuse legitimate medication or provide easy access to the medication to other residents. Understanding different medicines as well as their use and abuse is the first step to knowing how an individual Oxford House should monitor and control the presence of legal drugs within homes. The use of medication lockboxes in houses will also be discussed. Following opening remarks by the panelists, the panel will focus on responding to questions from the moderator and the audience members. The panel consists of medical experts and Oxford House alumni experienced in dealing with these issues in Oxford Houses. And first, we're going to hear from Dr. Ken Hoffman.
This is one of the highlights of my year, coming to Oxford House, and this is a topic I do like to speak, and I try to revise it every year to hopefully be a little more efficient, and so here we go. I could do all these things. I'll cover this outline, but I think it become obvious, I think, the direction that I'm going with this. The first thing is, you've heard about the disease of the brain, changes in the brain, and this kind of reflects, the nucleus accumbens, which is the area that gives you that nice pleasurable response when you use a drug of addiction will generally be first noticeable by this is working, this is really pretty wonderful stuff. The memory is in the hippocampus, so, mind learns to remember these things, and then the amygdala is the action place, and then the cerebral cortex is where all the decision-making, planning, and everything else, the executive functions are kind of being pushed into place. So if I go to the next one, this is relating to body and mind. Start from the bottom. The heart, if it gets attack or in some ways insufficiencies happen, a real degradation in the metabolism of the heart muscle, and that's the one on the left. And then on the right is the health. The left is the healthy heart, and the right is the diseased one. Well, the same thing happens in the mind too, in terms of metabolism. If you look at the one on the right being what's happening over time with a person abusing cocaine, a stimulant, and what's going on the left, which is the healthy mind. And drugs are really more of a problem the earlier they're used in one's developing life, and the brain really is continuously changing, but really rapidly changing between the ages of 5 and 26, actually. But these are just diagrams of showing the development of the prefrontal cortex, which is where all the decision-making. So take tobacco. I don't think there's anybody or very few people start using tobacco, after they're age 21, but earlier on, when the brain is developing is also when tobacco is using. It turns out to be, between inhalation and everything, one of the most difficult drugs to basically recover from, because of the time and delivery of that particular drug. Tobacco companies have done a fantastic job in their research figuring out how to get middle school and high school kids to smoke. This is just a kind of a time thing, but I think it explains why recovery takes time. You have a healthy brain. This is now dopamine receptors, which have been downregulated in someone who's been, say, abusing methamphetamine. And the scans are of people who abuse drugs at the time, so you don't get everybody. But I think it illustrates that what's happening in that dopamine receptor system, which have now been downregulated significantly. And now this is the group that, if I don't take a stimulant, I'm going to feel really, really bad. And it's not it's just the way the body's responding at that point. But after a year or two, this is the brain now 14 months later on the right side that has recovered. So meanwhile, it's kind of a rocky road between, for that 1 year to get to recovery. Now, this was a kind of a re-engineering process we did, and I think I'm reframing this a little to the diagram of who you are as a person, which in data could be defined, biopsychosocial, but the biological status, which is now the, physiological response to the medication from an intoxication or withdrawal viewpoint, and all the other biomedical conditions that are being treated with a variety of different medications. Now, where we are in recovery is really looking at your psychological and your social factors. So you have the psychological condition, alcohol, drug use, treatment acceptance, spirituality, relapse potential, that all goes into that initial triage and assessment for someone coming into treatment. But when you think of recovery, those are really the areas that become highly important in terms of how do you get from point A to recovery. Social status are the components that usually are not a focus for medical care, but it's extraordinarily important because that's kind of where your 5 senses connect. It's not to me in a 10-minute encounter as much as it's going to be for 160 hours a week. Who are your friends and where are you living? So the biological, quickly, you have the life-saving medication support. I don't think anybody would even get in the way of this one. Narcan, if someone's overdosed, get them the Narcan. We're not going to say whether or not you should use Narcan, just give it to them. Benzodiazepines also have an antagonist out there. And what this will do is it'll throw someone into withdrawal, but it will also bring back the breathing and heart rates and things like that. And then the supportive care. In withdrawal, the same thing is you want to keep people comfortable. It's not to torture people and to kind of have the most horrible experience. You have an opiate withdrawal, which is not normally at all deadly, but horrible in terms of its discomfort. And so you relieve that discomfort through detox regimens, which can include opioids, and with the benzodiazepines and alcohol, might include then the benzodiazepines. And then the biological conditions are all the other drugs. Okay, now we get to the psychological status, and you have the psychological condition, which can be used. And I think, the bottom line here is going to be, the medications are not the end point. Your behavior, what you're doing every day in recovery is what the important thing is. The medications are really more of a catalyst to help you get there. It's rather than spending my entire day trying to get out of bed or trying to, associate with other people, anxiety, depression, irritability, the medications kind of may help to decrease that level of those symptoms to a point that I can do the other things, but then it's important that I do what I can do. You have the alcohol withdrawal, say the anti-craving and deterrent medications, it'd be Antabuse or, the naltrexone, acamprosate, topiramax, gabapentin, throw out a few names. The idea of an anti-craving medication is that I don't feel like using it, or why did I bother? So it's, it's just the urge is gone, the craving is gone, or less. The treatment acceptance, that's the other component. Well, what medication helps that? Now, we usually talk about stage of change. I'm taking action. I got to do something today. It's not going to be easy, but I'll start. And the medications may help you get there, but if it's all about medications, I've seen this happen too. Well, I'll give you some Librium so you may think about stopping drinking. It's like, well, that may not work very well. But in context of someone in an Oxford house, I'll be using a whole lot less medications, and you're already kind of in that treatment acceptance, and I'm going to do things. And it's going to take 6 months to a year until you're really, really comfortable with, or you're starting to get real comfortable with where you are. Spirituality, what medication helps that? I don't know. People could talk about peyote and some of the Native American, but even ceremonial wine, that's usually not the big issue. And the relapse potential, this is where you're getting into, longer-term use of the anti-craving and deterrent medications, but it's really the relapse potential is about where you're at and what do I need to do to prevent relapse. And so it's what you're doing every day, not the medications you're taking. Now, if you start to do, and this is where, it becomes kind of a important thing to figure out who your providers are going to be. Now, the social status, I can't think of really any medications for most of this, but family and friends, which is where a lot of abuse can be taking place, misuse, and developing addictions. But the idea here is that the medications are being used as prescribed, and hopefully there's a trusting relationship with the providers in a way that, that they can detect when, there might be some difficulties with those medications. Occupation, recreation, education, legal, again, important pieces of recovery, but not necessarily addressed well with any medication that I can think of. But medications of concern. Now, this is where I think we talk about the Oxford House, what is getting in the way of good recovery. It's usually these medications that have high and middle abuse potential. And so, I usually look at that in terms of how can I avoid using these medications. There's some practitioners that would first use these medications. So that's kind of a, be careful. I mean, how many people have actually been to a physician, nurse practitioner, physician assistant prescribing medication that you feel actually knew something about addiction and could be helpful? So look, it's a few. So that correlates well with the number of people that actually do know something about addiction, given the whole field. So that's actually a big problem. Where's your trusted network of providers? I personally, if I knew someone was living in an Oxford house, I would have a totally different approach. I mean, not totally different, but I would approach treatment a whole lot differently than somebody who's done a harm reduction. I just want to keep them alive tomorrow, But here we have concerns about medications generically. For all the prescribed medications, it's the drug company that does the research, they do this, clinical trials, they pay the FDA to do the reviews, independent scientific panel, they get on the package, the label is on-label use. What you're concerned about are the black box warnings, which is totally the opposite of the intent of the medication, acute suicidal thoughts. Well, an antidepressant's not supposed to do that, but for some people it really happens. It's like, oh, stop. Tell me about it right now, we'll change to something else. You have the serious and common side effects, and there's a commonality in there too. And what works in one person, the same class, the same medication, may work totally differently in somebody else. So again, that's the, talk to your provider about that. Drug-drug interactions are always there. And some, I look at, one drug is better than two drugs better than three drugs. Polypharmacy for me was kind of a dirty word. And, after three, you're kind of wondering what's interacting with what. But if you know what they are, then fine, And not you, but you and the provider. The metabolites and metabolism. Everything goes out through the kidneys or the liver. Pick one, but they go out, they have to get out of the body one way. Actually, they go out through the lungs too sometimes. And for the same thing on the prescribed medications, the same is true for the over-the-counter medications, alcohol, tobacco. These are all drugs, and marijuana. Same concerns. By the way, tobacco is an interesting one because you usually don't think about interactions with tobacco, but it really does. It stimulates liver enzymes for processing and actually can enhance the getting rid of certain drugs. So, you know, you're going to get like caffeine leaves faster with tobacco than without tobacco. So if you stop smoking, actually, you know, caffeine is, I don't need as much coffee anymore either. But the same would be true with some of the psychotropic and other medications and opiates, yeah. So what makes the drug addictive, it's that immediate pleasure and the speed in which it reaches the brain. So take tobacco, the fastest way to get a potentially addictive drug to make it most addictive is to throw it through the lungs. So methamphetamine, crack cocaine, tobacco, you know, goes through the lungs. The action on reward mechanisms, genetic predisposition, and this loss of control, which is where the addiction starts to kick in, the psychological. Now, the physiological factors, the other piece of it, and sometimes you're intending the drug to do this, most of the time we're not. Drugs are miracles until people realize there's tolerance developing and it doesn't have the same effect anymore. And if I stop using it, I really feel bad. Stimulants, like that first picture, dysphoria, sleep disturbance. I mean, it just goes on and on. I can't focus. I can't do this. I can't do that. So again, there can be a genetic predisposition and side effects coming from those medications. The usefulness, I think, for where we are in Oxford House will be its use in support of recovery goals. It's not an end to itself. Some people, you know, just because I took the medication doesn't mean I'm cured of anything. It's a catalyst. It's a risk. Relapse risk symptoms are targeted for improvement sometimes and has low abuse potential. And it should be prescribed by somebody who understands recovery, you know, and that's an open, trusted patient relationship. So something that an Oxford House or people living in an Oxford House can do is sort out who in the community you would actually trust to take care of you and know that if someone asks you, who do I go to, you have that network. It's because there's others that, you know, you have gas and go operations, basically. I don't know if you know where the phrase came from. Does anybody know gas and go? But it was back in New Jersey might have a better sense. But you go to a gas station, a full-service gas station would, put gas in the car, but they would also check the tire pressure, the oil, you know, clean your windshield. So it's kind of like a preventive maintenance on your car, anything that we need to worry about. Otherwise, you know, I just, put the gas in the car. So if a lot of medicines turned out to be that way. I have 15 minutes to see you, your 99213 coding type of thing, and 15 minutes, and I have another patient in the waiting room. That's not integrated care. And so there's a lot that has to be done in that short period of time. So this is a trusted network of physicians. They're out there. It's just a question of who you would develop a relationship with. And that you represent a healthy, I think, supportive social environment that I think can enhance the patient-provider interaction. You as a family, a patient can give permission to interact with the provider. But it's you can be part of the process of helping a person achieve what their goals are, which is recovery. And I know that if they're living with you, that there's a much better chance of that. Any questions? When in doubt, ask questions. Okay, so I think with that, I will conclude my bit. And thank you. Take this away.
Thank you, Dr. Hoffman. Next, we're going to hear from Kimberly Nelson, who is the SAMHSA Regional Administrator for this area.
Thank you. Quite all right. That will for sure trip me. Good morning. There's a cord up here, and I will trip on that. Good morning, you beautiful recovering people. It is so amazing to see a room this full at 8 o'clock in the morning on a Saturday. Rainy. Good morning to stay and sleep, but here you are. So that's just awesome, and I feel grateful to be among you. So I am the person from SAMHSA who was supposed to be here was Dr. O, we call him. It's because none of us can pronounce his last name. He's a wonderful man. Dr. Ahua, I think is, but he is in DC and could not come, and so I'm filling in for him. And my first disclaimer is I am not a doctor. So good thing we have Dr. Hoffman here and other doctors that can speak to the, these components that he just did. I'm here to kind of talk with you about SAMHSA's position around medication-assisted treatment, and so that's what I can offer. And so SAMHSA recognizes, I talked a little bit about this yesterday when I was here, SAMHSA recognizes that medication-assisted treatment is an effective, evidence-based treatment when coupled with counseling and other services. Just like Oxford House is an effective, evidence-based practice, right? SAMHSA also recognizes that. So, for those of you who don't know, SAMHSA is the federal agency who's provides leadership on addiction and recovery, mental illness, substance use disorders, and so we maintain kind of evidence-based practice catalogs and provide resources, et cetera. So, SAMHSA recognizes medication-assisted treatment is an effective evidence-based practice, especially for certain types of addictions. At the same time, we also recognize the unique challenges to medication-assisted treatment and being in an Oxford House. It's not like, we don't understand that at SAMHSA. It's clear that there are some things that have to be considered. But particularly now that all the eyes in the nation are on this opioid crisis, right? You can't turn the TV on without hearing about it. I mean, it's a lot of us know that addiction has always been a crisis in our country, right? Well, what's happening with the opioid use disorder crisis, though, is just more people are dying, and so it's gotten attention. And opioid use disorder and other addictions, alcoholism, those are, we deal with chronic illnesses. These aren't acute illnesses, they're chronic, which just like heart disease or diabetes, it just means that if you have addiction, alcoholism, you are managing that condition over your lifetime, right? We don't just kind of go to treatment, get well, or go to detox even, get off the substance, get well, and we have to deal with the living part of our illness and changing our lifestyles so that we can continue to recover. And that's, Oxford House is all about that. This is where recovery happens. Treatment may be kind of the initial stage of getting into recovery, but you have to have supportive, all of the social conditions to maintain recovery, right? So we recognize, that we're dealing with a chronic illness. And when you're dealing with a chronic illness, you may need medication chronically. So again, I compare to diabetes, which might be a worn-out comparison. You may have heard that a lot, but someone who, if anybody has diabetes, that you manage that with behavior change, yes, behavior modifications, but also potentially with medications. We look at, especially when we look at opioid use disorder, the chronic condition and the need for medication is going to vary 6 months, a year, 18 months, 2 years, who knows? It's really based on kind of that patient-provider relationship and figuring that out. So, numerous studies show that if someone discontinues medication with opioid use disorder too soon, and or if they, just in that process of discontinuing that medication, there's a high potential for relapse at that time. And when you've been on medication, let's say one of these medications, methadone, Suboxone, maybe naltrexone also, when you've been on one of those medications and you stop, and then if you relapse at that point, your risk to die of an overdose is huge. It's just, tremendously increased. So this is why we just pay close attention to what's happening, especially with opioid use disorders. despite the research that kind of shows what's happening with the brain and with this chronic condition, we know that many recovery housing environments still are hesitant to have people on medication-assisted treatment or medication-assisted recovery living in their houses. We know that. And that practice can result in somebody getting off of a medication maybe too soon or abruptly, and or keep someone from accessing a great resource like Oxford. So it's not a simple problem, though. In order to effectively use medication-assisted treatment and live in an Oxford house, you obviously, as Oxford House members, have to have some rules around how you keep safe that medication that can be diverted, right? And I know others are going to talk about what that looks like. But I want to talk just to you about 2 activities that SAMHSA has going on to kind of address this challenge, this tension. And the way that I think about the tension between somebody who needs medication to help with their recovery and also wants to live in recovery housing to help with their recovery, that tension, it's like, you know, Oxford has this kind of essence of who you are and what you do. And anytime there's progress in, you know, like with treating addiction, we've seen some progress in what that looks like now. You know, for somebody with opioid use disorder who, you know, previously didn't maybe have as good of access to something like Suboxone or some of these other drugs, now their chances of recovery may have been less. And so now we have these medications. It can improve someone's chances of recovery, but then there's the tension that comes up with, you know, wanting to be a part of a recovering community, but being on a medication that, you know, is a partial opiate. And so I think that tension kind of can be described as, you know, Oxford needing to hold on to the essence of what you are while adapting to what's happening in terms of the science out there. And that's a difficult challenge. But we got to talk about it. We got to, you know, deal with it. So SAMHSA in DC has formed a recovery housing work group. So recovery housing continues to get lots of attention because it works. And so this recovery housing work group that's been formed at SAMHSA is really just about trying to figure out what are the best practices for recovery housing. And then secondly, did you hear that the opioid bill passed in Congress? Anybody hear that? Well, it did. Yay. This is a good thing. Yeah, you know, it's amazing that we live in a time when Congress is paying this much attention to addiction and recovery. We've never seen a time like this before, but that is what's happening right now. And so what happens when Congress pays attention to that is there's the potential for resources to be developed to help us, those of us that need it, get into recovery more frequently. You know, most people that need recovery and treatment and supportive services don't get it. Those of us that are sitting here are kind of among the lucky few who actually access services, you know, whatever resources we need to get into recovery. The vast majority of people are still dying from our disease. So when Congress pays attention, they get these resources going, we hope that, you know, it makes a bigger impact, a bigger dent on the people who actually need what we get to have. So the second, you know, thing, so we've got this work group going on at SAMHSA. Well, now that the opioid bill has just passed, literally on Wednesday night that happened. Yeah, big deal. And it takes a lot to get something through Congress these days. Let's not even start that discussion. But, you know, the fact that we can have bipartisan support on the issue of addiction and recovery, huge, huge. So next year, or maybe 2 years from now, this room will be twice as big. You won't be able to meet here because there won't be rooms big enough, you know, because we know that many people need to get in to services and recovery. So there's a section of this bill. I want you to pay attention to this. You'll start hearing about it. Hopefully there's a section of that bill. It's section 7031 that charges the Secretary for Health and Human Services, which is SAMHSA is under Health and Human Services in the federal government, charges that our secretary, which will likely come down to SAMHSA's leadership, our assistant secretary, leading an effort to establish best practices for recovery housing. Oxford will certainly be at that table and be part of that discussion. Medication-assisted treatment's also going to be part of that discussion. How do we make these two things work together? Yeah, we have to figure it out. We have to figure it out because, lives depend on that. So, obviously, living in stable housing and having a supportive community are things that you have to get into recovery. Oxford does that well. Medication-assisted treatment, I think it's important for us to remember, is not just replacing one drug for another. I think we often hear, oh, you just got off of the heroin and on to the methadone. Oh, it's the same thing. It is not the same thing. If anyone's been on heroin and has been on methadone or Suboxone or naltrexone, it's not the same thing, right? It's not replacing. People that are on medication-assisted treatment lead productive lives, have jobs, get to maintain housing, get to have relationships in their life, all these things that we all want. When you're on heroin and or, fill in the blank, other opiates that you're having to go find on a daily basis, sometimes multiple times a day, having a life in recovery isn't possible. Holding a job, whatever, being able to stay housed, having relationships with your family, you can't do that. When you're on Suboxone or methadone, you can do those things. And I know people personally that are doing those things and are in recovery. And so I really look forward to hearing from you, talking about this. We got to be able to talk about this. It can't be some big elephant in a room that we never talk about. We got to just talk about it because, and I just want to share, I'm going to take off my federal hat and put on I'm a person in long-term recovery hat, okay? And I want to just share, a couple stories, I guess, about this from myself personally. So I have, my recovery is abstinence-based. So I got sober on November 6, 1991. Gotta love those November dates. Yay! Yay, November! And have been sober since. I'm lucky, but I manage my chronic condition every day. This morning I got up and I did what? My prayer and meditation, right? And I asked for help to go be a helpful person in the world, and I did, that's a daily thing. I talked to people that I help, that I mentor in the 12-step program that I work in. And one of those people just celebrated 5 years on October 1st. The other one yesterday celebrated 3 years, and I've got one that celebrates 21 years tomorrow. So, yeah, so I had, it's awesome. I had texting conversations with a lot of those people today. These are the kind of daily things that I continue to do to manage my chronic condition, right? To stay in recovery, because I know I'm really lucky to get to be here. So, but I have this kind of, it'll be 27 years ago that I got into recovery. I was 23 when I got sober. So, yeah, that means I'm 50. I'll do the math for you. I can't believe I'm 50. But, 50 in recovery is better than, I wouldn't have made 50 before. So, yeah. So I just say, it was abstinence-based. There was not a lot of, medications have been around a long time, but there wasn't the opioid use disorder crisis back then. So we didn't have a lot of people kind of in that boat. And so I had my own bias, is the story I want to tell you. I had my own bias about recovery, and people on medications weren't, quote, really in recovery. I had, because I got sober in an abstinence-based model. Well, what happened is two things happened. One is I started working in this field. I'm a licensed addictions counselor, and I ran treatment programs mostly for women and kids in the community, but also in the prisons. So in the prison-based programs that I ran for a while, I saw people with opioid use disorder come in, and you couldn't take medications when you're in prison. And so those people suffered, and not, I mean, they suffered withdrawal initially, but once past that, their brains were different and they could not kind of grasp what they needed to grasp in those treatment programs, and they ended up just kind of spinning out. I saw it over and over and over, and there was something different about people with opioid use disorder than, for instance, methamphetamine. It's different. It's different. So I saw those differences. I also saw, I started meeting people in recovery on medication and listening to their stories and seeing them be able to hold jobs, get families back, you know, I mean, just have those things that we all want to have. That made an impact. And then lastly, what made an impact for me was I had a sister who married a guy who was, you know, like us, had addiction and opioid addiction and IV drug user. And it turned out that they both ended up, he was in recovery even, but they both ended up dying of HIV. So they died of AIDS in the 90s. And those are just some things in my, and that was my only sister, you know? That was so painful. Those are things that have impacted what I think about recovery and how, you know, we have to allow the many paths that there are to recovery. Who am I to judge what your path needs to be? It's not for me to judge that. It's for me to, you know, be helpful to you, whatever your path is, and help save your life, you know? That's what we all do for each other. It's, you know, life and death. So I just wanted to tell you, you know, those couple things, and hope, you know, I can be helpful in any conversation about this. So, thanks.
Thank you so much, Administrator Nelson. Next, we're going to hear from Paul Stevens, who's a regional manager for Virginia, D.C., and Maryland.
Morning. My name is Paul. I'm a person in long-term recovery. I consider having to be coherent before 10 a.m. cruel and unusual punishment. I'm going to give it a shot. Oh, I do have a PowerPoint, too. That decision was made at about midnight, so we'll see how this goes. Okay, great. So I've been with Oxford House for a while. I got clean 17 years ago. I started working for Oxford House 14 years ago, and that entire time up to this day, medication in Oxford House has always been and continues to be a pretty controversial subject, a tough one for the houses to figure out and deal with. Let me just also mention, I appreciate Ms. Nelson's excellent introduction on medication-assisted recovery. I just want to point out, too, that we're going to have another session. It's right after this one. One of the breakouts in the next session is going to be all about medication-assisted recovery as well, so you have more interest in that. And if we have time for Q&A, maybe we'll save the Q&A that's specifically related to medication-assisted recovery for that session. There'll be a bunch of other people on that panel. Okay. So, and normally I have to qualify that I'm not a doctor either. We did hear from one doctor and two experts in addiction, so that's great. I am not an expert in addiction. I will try to provide more of an Oxford House perspective on medication in Oxford House, although I do sometimes feel like being an outreach worker, or frankly even just living in a house or being a chapter officer, requires a degree in pharmacology, as does being an addict sometimes. All right, so, no? Which way am I supposed to point? Oh, great, okay. So I want to start briefly by just touching on a couple things that I've learned from addiction experts like Dr. Hoffman or Dr. Gitlow, who, by the way, will be speaking in our general session later today. You do not want to miss that. He's a great speaker. And I think Dr. Hoffman touched on one of them, which was just that, you know, most physicians don't know a lot about addiction. They're not well informed about addiction medicine and how to properly treat individuals with our disease. So sometimes they're a little clueless about what to do with us, drunks, druggies, and crazies. There were two major studies several decades ago that many experts argue used questionable methodology and created a misunderstanding that the medical community that dual diagnosis is extremely common. Dr. Gitlow and others argue that it is not as much the case. Doctors diagnose individuals with substance use disorders as dual diagnosed because they treat the anxiety or depression as a separate disease instead of recognizing all the ways that the extended substance use creates physiological anxiety and depression. The anxiety and depression that we feel when we're using and when we first get clean is in 90% of cases a product of the substance use. Most addicts don't need psychiatric medication. However, most addicts are prescribed psychiatric medication because doctors are often ill-informed about substance use disorders, and they treat the symptoms of substance use as they were their own separate problem. Addiction specialists do acknowledge that in 10% of individuals, the dual diagnosis is legitimate, so I'm not suggesting that, nobody has to deal with depression and anxiety or bipolar disorder as well as addiction. They absolutely do, often. According to Dr. Gitlow, it takes 6 months of abstinence for the anxiety that is physiologically generated by substance use to wear off, and it takes a year for the disruptions in sleep patterns that are caused by substance use to wear off. So the good news is that many of us who think we're both addicts and crazy are not. The bad news is that we think we are, and many of our healthcare providers we deal with think we are, and we often all end up overprescribed medications as a result. So in addition to addiction specialists talking about a similar story that's led to the massive overprescription of painkillers in the U.S., which has been a significant factor in the opioid epidemic, we heard yesterday morning from a doctor who talked about this, so I'm just going to very briefly summarize that issue. Just a couple numbers real quick, too. There are over 70,000 lethal drug overdoses that occur each year in the United States. At least that's the number for 2017. That's 192 deaths every single day. That is 1 every 7.5 minutes. Almost 20,000 of those involved prescription opioid pain relievers. And I don't have statistics from 2017 on this, but from a couple years before that, at least 7,000 people are treated every single day in a hospital ER for some kind of an overdose. And in recent years, anywhere from 2/3 to 9 out of 10. You want me to switch? Yeah, really? It was. I think we're okay. All right. I want to just skip ahead. I want to give Daryl some time to talk as well here. So there was a confluence of different things that occurred about 25 years ago that led to this overprescription. Well, for starters, about 25 years ago, the heroin coming into the eastern United States got much purer. It allowed people to start snorting it instead of injecting it. It led to a significant increase in users, a different population of people that were interested or willing to become involved in opioid use. I was one of them. And at the same time, there was this, and she mentioned this yesterday, this sort of shift in focus on treating pain as an objective vital sign. In addition to that, hospitals were starting to look at patient satisfaction more as a focus on how their hospitals were doing, instead of well-being, perhaps. I mean, what better way to have a patient who's experiencing pain leave satisfied than with a big fat bottle of oxycodone? And over that period of time, the prescription of opioids from about 25 years ago to now has increased by tenfold. And this doesn't get talked about as much, but even things like sedatives, benzodiazepines, Ambien, things like that have increased in prescription by at least fourfold over that time. So a lot of increase in prescribing of those drugs. Okay. So let me sort of shift to a perspective that's more about Oxford House and how we deal with these things. So first and foremost, I will say Oxford Houses are total abstinence and zero tolerance sober living homes. That's the foundation of what Oxford House is, and one of the main reasons we're so successful at helping people. People achieve long-term recovery in Oxford House, and that model is, obviously a big part of why. The Oxford House model is based on the idea that addicts do and can know everything they need to know themselves in order to operate a successful recovery house. You guys know what active addiction looks like. You know the signs, you know the behaviors, all too well, right? You are capable of determining for yourself what using looks like and what constitutes recovery and what constitutes abstinence. I say this because there are no specific drug prohibitions in Oxford House. Our houses and the members in our houses are drug-free, and what that means in your house is something your house needs to determine, individual by individual, applicant by applicant. Oxford House used to have a prohibition against methadone. I'll be discussing that a little bit and some other people in more detail in the next session. But fortunately, that prohibition was lifted in 2010. At that point, the organization decided we don't need to tell you what recovery looks like and what it isn't. You can and have to decide. We never had an explicit prohibition against cocaine or cannabis or methamphetamine because we don't have to spell out what substances are okay for people claiming to be in recovery and which are not. You're capable of figuring that out. All that being said, there are some very clear guidelines that Oxford House can provide you. There was a memo put out a few years ago by Oxford House World Services that touched on this. I actually thought I had that in the slides. I don't, but what I'm about to say pretty much summarizes the entire memo. It was very short. Before I talk about that, though, let me just touch on a couple procedures. First, the application. Application for membership asks the applicant to list all prescription drugs and indicate the reason they're being prescribed. You need to go over that with the applicant in the interview and make sure they have answered that question thoroughly and honestly. Okay. When an applicant is accepted and admitted, the House also needs to have them fill out, among a few other things, an emergency medical information form. This will also ask what medications the member is taking. And when prescriptions change, any prescriptions really, the House member needs to get with the president, is often the person, at least in my area, pull out the paperwork and update it, and then sort of touch on that in the House meeting. But there's a larger point I want to make here, which is if you have an applicant or a member or perhaps even yourself feel that when medication, what medications you take are your business alone, it's between you and your doctor, it's not really how Oxford House looks at it. Not if you want to live in an Oxford House. What medications you're prescribed can be of interest or even concern to the House. And if you're not okay with that, you probably need to live somewhere else. Let me quickly just address the term narcotic because that's sort of included in the memo. There's a number of different definitions. For the purposes of this discussion, I mean it and the memo means it in a very broad sense. So here's a sort of a dictionary definition of narcotic. Any of a class of substances that blunt the senses as opium, morphine, belladonna, and alcohol that in large quantities produce euphoria, stupor, or coma that when used constantly can cause habituation or addiction and that are used in medicine to relieve pain, cause sedation, and induce sleep. Second definition, a drug such as cocaine, heroin, or marijuana that affects the brain and it is usually dangerous and illegal. There are a number of prescription medications that can potentially be problematic in Oxford House. Sorry, I got a little behind there. Opioid-based pain medication, benzodiazepines, certain medications taken for sleep, such as Ambien or Lunesta, barbiturates, and certainly also as well ADD, ADHD medications, Adderall, Ritalin. And there's a common theme here, right? I mean, most of those drugs are drugs that people have historically used recreationally to get high. But please remember that common sense needs to come into play here, right? We're not suggesting the House needs to start worrying about things like, SSRI antidepressants or high blood pressure medication or what have you. The majority of prescription medications are perfectly acceptable and uncontroversial. So here's a quote from that memo. Any member prescribed narcotics by a physician must have a letter from his or her doctor acknowledging that they are aware that their patient is a recovering alcoholic or drug addict, and that in their professional opinion there is no alternative or suitable non-narcotic medication for their condition. I would add to that that it ought to include that the doctor acknowledges that that patient is a member of a total abstinence and zero tolerance recovery home. The memo also says the letter should also state the length of time the patient should be on the prescribed medication. It goes on to say, in addition, the group conscience of the house must determine if the presence of narcotics in the house might trigger or have a negative effect on their own recovery and vote accordingly, keeping in mind that we are a zero-tolerance program. So just because the doctor prescribed it doesn't mean that you have permission to go fill that prescription and start taking it without first discussing it with your house. The memo references a vote, right? The house needs to vote to approve medications before the prescription's filled, before the member has taken any of the medication, and obviously sometimes that's not possible. Again, let's not lose track of common sense here. Sometimes people end up in the emergency room, they end up at a hospital, they get administered medication. Like, we cannot expect them to tell the doctor to stop saving their life so that they can call an emergency meeting to get permission, right? If the house approves a medication with a letter from the doctor, with the information that's necessary, then we have to concern ourselves with monitoring that medication. First, always look at the bottles, check prescriptions and medication bottles. If they're being written by different doctors, big red flag. If medications are being filled out at different pharmacies, that can be a red flag too. The house needs to see what the directions for use are. But we are not healthcare providers. It's against the law for us to hold someone's medication. We can and should insist that they keep it locked up in a box in their room, so there's no chance that other members will be tempted to take any. Pill counting is one of the methods we use to monitor that. That's usually typically with 2 other members present. Sometimes houses do it at the weekly house meeting. And it's important that we remember, you guys need to insist that your members take prescriptions as they're prescribed, right? I mean, and this is true of some medication that's not even as controversial. Members stop taking prescribed medication for depression, or particularly for bipolar disorder or other personality disorders, they'll often start behaving in a way that is not only unhealthy for them, but can be disruptive to the house. So it's not just don't take too much of it, it's make sure you take what you're supposed to as well. Misuse, abuse of prescription medication is considered a relapse in the house, and you guys have to decide whether that has occurred and what that means. I'll just close by referencing Tradition 7. This talks about the idea that we can either suggest, and sometimes if the person's behavior is of enough concern or disruptive enough to the house, we can insist that they seek professional help. Tradition 7 says, within an Oxford House group, it is not unusual to find some members who have problems that cannot be dealt with by the group. In those situations, it is not uncommon for the Oxford House members at a meeting to strongly suggest that a fellow member seek professional help. In those situations where a member's behavior is disruptive to the group as a whole, the member may be required to seek such professional help. That's all I got now, and we'll get to hear from Daryl, and then hopefully we'll have a little time for Q&A.
Thanks so much again, Paul. Next, we're going to hear from Daryl Joyner, Oxford House alumni and central office staff, aka the voice of Oxford House.
Good morning, family. Can you hear me? Is this thing on? Okay. Good morning, family. I'm Daryl. I'm a gentleman in long-term recovery. What that means, I haven't had a drink or a drug since March 18th of 2000. Now, I don't have any special video to show you, so I'm just speak from my heart and tell you that without living in an Oxford House, I probably would not be standing before you. I'm also a gentleman that is living with the HIV virus. I was diagnosed with that, talking about a November date, was November 26th of 1999. Or, excuse me, 1989. And I'm still here today, you know. When I came into an Oxford House, you know, we all had to fill out that application, right? Paul mentioned it. Box 21 stresses what medications are you on. I just figured out probably why I did not get elected into the first 2 houses that I applied to, because I knew I had aced the interview portion of the questionnaires, but I had a long list of medications that I was taking, because that's what it would required back in the early days of HIV, right? And it probably scared most of the houses, or the houses that I had applied to. You know, I was also in the program that was talking about harm reduction, and it was at that class that I actually was introduced to Oxford House. My addiction counselor told me that, why don't you go live in a recovery house, Daryl? Because I was living with my uncle, and he liked to do his thing, and I was new in recovery and all this other kind of stuff. So I took her up on her suggestion. Like I said, I went to 2 interviews, knew that I had aced the interviews, and got 2 rejections. It was probably box 21 that really got me not elected into our house. But anyway, moving on. I'm here today to say that, you know, when you all read box 21, Paul stressed it, that you need to ask questions about what the medications are for. You know, there's been many progresses in the HIV community that it doesn't require a long list of medications now. I'm on a 1-day regimen now, you know. So if you find someone that looks like me, that takes medication like me, simply ask, you know, because you actually will be helping that person by giving them a stable household to live in. That's first and foremost. What probably really got me still being here today is having a stable roof over my head. And I owe that all to Oxford House. I also owe it to the young men that I have lived with also, because they finally did ask the questions. And I'm not afraid to share the story whenever I'm asked about it. I'm not afraid to tell my story. So, when you get residents, they come into your house and they may have all of these listings of medications on box 21. Don't be afraid, people. Pick up your big boy pants and your big girl pants and start asking questions, okay? And that's all I have to share with you all. All right, thanks.
Thank you so much, Daryl, and thank you again to all of our panelists. I just want to say real quick, I've lived and been around Oxford House for almost 3 years now. I'm one of the type people in recovery that a 12-step fellowship would not have solved all of my issues. I've had to seek additional help from outside resources and agencies, PTSD therapy, and I have to take medications every day to treat my trauma and other stuff. And living in Oxford House, even still, like I have medication that goes in my file cabinet and it's locked up, and if my doctor changes anything from an antibiotic and a steroid for having a sinus infection to reducing my antidepressant, like I still update the paperwork in my Oxford House. I see my guys in a weekly house meeting and I let them know what's going on with me. So I'm a pretty big supporter and very proud to work for Oxford House, and the fact that out of all the different recovery organizations that are out there in this country, that we do support and leave up to the houses the right to make so many decisions for what we do accept and what we do tolerate in Oxford House versus a lot of different recovery organizations that are very limited, even exclusionary on what they allow in their houses. So you all are part of an elite organization that's definitely part of the dialogue at the federal level and everywhere else, kind of creating a new standard for recovery houses. So be very proud of who you are and what you're a part of with Oxford House. We have a few minutes for a few questions. If anybody does have a question, if you want to line up right here at the microphone, and we can ask those questions and see which one of the panelists can best answer them for you. Just go one by one. Make sure to speak loudly into the microphone so we can hear you and your question, please.
What is the Oxford House position on this kratom?
It's not allowed. It's not allowed.
again, you know, houses need to make decisions, but kratom, really? Is that controversial? You get high on it, right? Yeah.
We
all
can't
right.
hear you.
I'm not aware of any legitimate medical purpose for kratom, so that just sounds like a recreational drug of choice to me. I don't think that's a terribly controversial one. It should not be allowed in Oxford House.
I mean, it's the same mentality, I think, as, you know, kratom has an opioid-like effect. Also, be aware that there's khat out there and there's phenibut out there. So if you're sensing that there's a, you know, the same process that people get addicted to things or psychoactive drugs, you know, that's not indicated.
All right, thank you all. Next.
I have a real quick question on PRNs and as needed or if needed. I got hemmed up by a case manager who the person took extra medication stating it was a PRN and he was asleep on the floor from overdoing it. How do we deal with that when they say it's a one every 4 hours as needed or if needed, and they're taking more than that, and their doctors are stating it's a PRN?
I have no idea what that means.
Dr. Hoffman?
Yeah, this is one of those things that taking action and preparing beforehand, that is there a possibility of interacting with the patient, the physician, but you know, there's usually a total limit on the amount per day, and then one has options within the time. So maybe, you know, throw Xanax as an example. Somebody who has, you know, 6 pills for the next 6 months, you know, that's not the problem. You know, because they're going to fly, they're going to do this, they're going to do that. The problem is, as you're saying, that, oh, I can take up to 3 of these a day. Okay, great. That's where you need to have the discussion. That's where you get into that network of good providers that can work with the houses and understand the houses.
And I think something else too is looking at what the as-needed medication is, you know? Is it something that's causing heavy sedation? What's the risk factor for addiction? Is it something like Motrin, take, you know, one Motrin every 6 to 8 hours is needed? Or is it...
I asked the doctor last year, didn't you state that as needed and if needed are the same thing? Yes. Right? Okay, thanks.
Hi, I'll try to be quick too. My name's Ann. I'm from Virginia. So what, you know, just speaking to the last gentleman who shared so bravely about his HIV status and applying for houses and potentially having been turned down by 2. I mean, does Oxford speak to protections for people with potentially contagious diseases that may be like, you know, because of ignorance or just group consciousness of a house, maybe like, you know, barred, like effectively, like blocked from even getting an interview or certainly getting accepted, you know, at a house? Is there any recourse, or is there any, you know, do we have any guidance to houses to at least have an open mind towards people who have a condition that they might be scared of, or like I said, might be contagious?
Well, not to my knowledge, because none of us are clinicians in an Oxford House, first and foremost of all. That's what we all need to remember. We're not clinicians. So if someone has a medication on there, like I just said, simply ask the individual during your interview process.
Okay.
You know, keep an open mind. Do not be prejudiced against that particular person because they're taking something that you're not. This is something that they're taking to keep their life going on. Okay?
Okay, thank you.
Good morning. My name is Michael. I'm from Richmond, Virginia. My question pertains to, I'm familiar with the policy of not locking up residents' drugs or prescriptions, but I do have a question. How can we resolve an issue besides counting pills during a weekly meeting, a resident hoarding his pills or taking all of them on one day and then having to call a rescue squad to come get him because he's OD'd on his prescription medications?
Why isn't counting pills the solution to that?
I'm not saying counting the pills he's supposed to have for the remainder of the month at a house meeting. But in this case, what this gentleman did is he waited till a Friday evening or Saturday morning instead of taking his pills during the week, which he's got access to, then getting really high and I have to call a rescue squad on him. How can we prevent that from happening in the future?
I know houses that count pills every day. I mean, if you have a high level of concern, or you're worried, or it's a person new in recovery, they'll ask them to pull the bottle out every day, every other day, something like that. It doesn't have to only be once a week if you've got a reason to be concerned.
Great, I'll keep that in mind. Thank you.
Hi, I'm Anissa here from Kansas City. I'm in human resources, so this is a question for the workplace. When it comes to medically assisted treatment, when somebody in the workplace tests positive and they say it's Suboxone, how is that compared to, say, opioids, and how should we treat that in the workplace? It's probably a doctor-related question.
Actually, first of all, there's a very specific group of drugs that are tested for workplace that's not as comprehensive as might be done on, for medical reasons. The other half of that is if the drug is in the test sequence, there's a medical review officer that's part of the process, so the urine will go back as a negative if there's a legitimate prescription for that drug and it's being taken as prescribed. And that's a discussion that takes place before the work site would ever know that it was positive. A lot of drugs like Suboxone may not even be in the test cycle.
Great, thank you.
Where's everyone going? Good morning, my name is Raquel. This question's kind of for the OHI that are on this panel. So there was mentioned earlier that when it comes down to medication and a resident being prescribed a medication, it's suggested to vote it in as can this resident take that? Well, where does the House and the resident stand when the House votes against this medication? Let's say someone's prescribed something and everyone's kind of against it. Where does the House and the resident stand?
I mean, living in an Oxford House is a choice,
Right.
I mean, part of the idea in Oxford House isn't that we expect the house to cater the model to our needs. It's that we have to be prepared to get on board with the way the model works for the needs of the whole group and the welfare of the entire group. There have been people living in Oxford houses that have been told we're not comfortable based on where you're at in your recovery and what this medication is, and the lack of our comfort with the fact that your doctor knows that you're an addict or whatever. You just simply can't take it if you want to continue to live here.
Right. Okay.
Throw a quick kind of an ethics seminar that I'm working in. That's a great question, because the other half of that is if it's going to threaten your recovery, you have to do what's going to support your own recovery. The other half of that is, do you know any of the other houses that might be receptive to people on that medication, have them apply elsewhere? But know your own network.
Yeah, my question pertains to the MATs and as far as we're concerned at our house, it seems like people are taking those more to get messed up than anything. And is there any taper down? Like, how often should they be tapering down? Like, how long should they be on it? Like, those are kind of those are our concerns at our house anyway on it. And
I think for the purpose of this presentation, this panel, since we got about maybe another minute left for one more question, like Paul Stevens said a minute ago, there's going to be a whole presentation panel done on medically assisted recovery here in a few minutes, and you'll probably get a lot of additional information from a bunch of experts there.
So you guys are going to touch on that at the MAT?
Yes, there will be tons of information and education on that subject.
All right, cool. Thank you very much.
We have time for one more question.
I got a quick question. Coy out of Coos Bay, Oregon. What's our guidelines for CBD oils?
Again, I mean, we don't have any policies about specific drugs, and I'm sure we're going to be confronting this one more and more and more. I mean, my understanding of CBD, it has no sort of, euphoric psychoactive ingredients in it, right? It doesn't have the THC that gets you high. But I don't have an answer. I think that it will, you've got to sort of look at it case by case in the situation in your house and what you guys are comfortable with.
I think something else too I faced in my area, I work and live in the Myrtle Beach, South Carolina area, and the DEA seized a large section of CBD vape oil from shops, and some of it tested positive for active ingredients and metabolites with THC. So we kind of suggest, we're trying to look at the reason behind why you're wanting to do CBD oil. They certainly has legitimate health and medical reasons that people do take it, but I think you have to get back down to the house and what's the reason that this person's taking it or wanting to use it in an Oxford house.
Thank you.
Yeah. All right. Thank you all so much for attending this first panel. Thank you to Administrator Nelson, Dr. Hoffman, Paul Stevens, and Daryl Joyner for attending.